Good evening, everyone, and welcome to another edition of Sibley's Discussing the Facts. We are joined this evening to have a wonderful discussion about breast cancer. We hope that you will learn a lot more about breast cancer, the prevention, the latest treatments that are available, and basically what you should be looking out for and how it affects different people different ways. But first, I want to go ahead and draw attention to the person who has been standing by us for many years right now as a joined us in co-sponsoring Discussing the Facts, and that is Reverend Dr. Donald K. Sadler, who is the pastor of New Morning Star Baptist Church. So I'm going to turn it over to you right now, Dr. Sadler.
Welcome to Discussing the Facts. Discussing the Facts is a collaboration between New Morning Star Baptist Church and Sibley Senior Association. We're grateful that you have joined us again, and each month we come where you are to share pertinent information about our health, and we bring to the forefront persons who are competent and capable and look like many of us and share the information that will help us become whole and remain healthy. We're grateful and thankful for this opportunity to once again share information and inspiration to all of you. And I want to begin by asking God to lift us and inspire us and give us the needed spirit that we need this evening. Let us pray. Gracious eternal God, our Father, we humble ourselves before your presence, thanking you for our lives and this assembly of persons who come today to open up their ears, their minds, their hearts to receive that we will be a better community. We pray blessings upon our moderator today as she gives leadership and the panelists that will share the information that is needed, that all of us will not just remember and reflect upon breast cancer during October as we wear our pink, but we will be our brothers and sisters keeper all year long. We pray that this information will enlighten us, will give us enrichment, and enhance our lives as we continue to grow and go. We ask this prayer and pray that it will bring peace and love to our hearts. Amen.
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 Thank you so much, Dr. Sadler. At this point, I want to go ahead and introduce our speaker. We are so happy that Dr. Princess Mark Ajelli, who happens to be a medical oncologist who focuses on breast and gynecologic cancers, is with us again. She is our very own. So we are happy that she, through her practice with the Johns Hopkins Kimmel Cancer Center, continues the outstanding work in helping persons, navigate the journey with breast cancer. There's a lot that I can say about Dr. Mark Ajelli, but I think what's most important is what she's passionate about, and that is providing, patient-centered care and finding the best individual plan for each patient through the various targeted therapies, the immunotherapy, chemotherapy. And I think the other thing that has been very important is that she recognizes gaps in cancer care and is dedicated to their eradication. So with that, I want you all to welcome Dr. Mark Ajelli to us once again. So thank you for wanting to take the time to join with us.
Thank you. Thanks so much for having me. It's always a privilege to be invited for these things, and thank you. Thank you.
Oh, you're so welcome. Breast cancer has been in the news not only this particular month, but just recently. And there are a lot of terms that have come up. And I thought that we would open our discussion first with kind of looking at some of those terms, making certain that we are all on the same page when we are talking about different types of cancer. So, one thing that has been in the news, we've heard about triple negative breast cancer. What exactly does that mean?
Sure. So really, in breast cancer, we test for various receptors, and these receptors are what guide us in treatment.
Mhm.
So the three types of receptors we test for are estrogen receptor, progesterone receptor, and a protein called HER2. That's why we call it three. So these are the three things we test for. When all three are negative, then essentially that's the name triple negative comes from. And that basically just telling us that there is not much to target in terms of whether it's estrogen, like what is driving the cancer? Is it the hormone in the patient body, like the estrogen or progesterone, or is this a mutation like a protein called HER2 that is driving the cancer? So the whole goal is trying to detect these three to see if any of these are driving the cancer forming, then hopefully we can go after it. But when all these three proteins are negative, then essentially it means that there is nothing really to go after in terms of the targeted drugs, like estrogen blocker or HER2 targeted, that is triple negative. So we cannot target any of these three. And that's where really the name come from. Go ahead. I don't know if you want me to keep on
Yeah,
going.
I was gonna say, I mean, from what I've heard and a little bit of what I've read, it's considered, an aggressive form of breast cancer because when it lacks those receptors that you're talking about, it means that it's less responsive to a lot of the drugs and therapies that exist. Is that pretty accurate?
Exactly.
Mhm.
So that's what really makes it the aggressiveness is the fact there's nothing to really go after. Like when a cancer cell is estrogen or progesterone positive, then we have a
Mhm.
targeted, pill that we can use to go after it, or
Right,
even the
right.
HER2. But when none of these are positive, basically none of these are driving the cancer cells. So then we are tied to often use chemotherapy as a way to target the cells. So it's just more aggressive because we're just blindly trying to target the cells.
Okay. Now, let's talk about, which women are more apt to have triple negative breast cancer. Are these younger women? What about African American women? Do we find triple negative breast cancer more prevalent in certain groups?
Yeah, so really more and more we are finding it more in African American or Black populations than the
Mhm.
counterpart. So it's really sad to say that it's aggressive type and also more common in minority population, especially the Black community. And there are some mutations that predispose patients to this breast triple negative, but somehow commonly is found in Black Americans, Black people in general than, say, a white population. Mhm.
When we talk about all of the different cancers out there, does this particular type of cancer have a higher rate of, say, recurrence or metastases, or is there
Yes.
anything
Mhm.
really?
Yeah, it does. And no, again, it comes back to nothing is really driving it in terms of, say, a hormone block, a hormone driving, then we can continuously go
Yeah.
after it. But because it's really just nothing to target, that means even when we treat it with chemo, patients are often at higher risk from having a recurrence. Like a stage one estrogen positive breast cancer, most patients can forgo doing chemotherapy. There are a lot of things that guide us, but oftentimes
Right.
may
Right.
not need chemotherapy. Whereas the stage one for a triple negative patient, we have to offer chemotherapy, even when it's a very tiny tumor, like less than 1 centimeter, even if it's like 8 millimeter, I am
Mhm.
bound to offer chemotherapy just because of the aggressive nature of that particular cells. And while it's really among all the breast cancer type, it's less compared to say estrogen positive breast cancer is majority of the breast cancer. Like we're talking about 70 to 80%. Triple negative is less than 20%, yet it's the most aggressive. And when detected, again, it becomes really hard to treat in the long term because they have high rates of coming back.
Thank you. Thank you. Another term that's been in the news, and I know in a lot of the seniors that I've been speaking with, you know, we've had discussions about that. I myself have had discussions, you know, with my physician about this. So can you kind of break it down for us? What does it mean when a woman is told that she has dense breasts? Particularly after having, you know, a mammography screening, they'll come back and say that you have dense breasts. What does that mean? And is it concerning when we're talking about diagnosing cancer?
Yeah. So really, you know, breast is made of a lot of fatty cells, and that is easily seen when something is hidden inside. However, when a patient have dense breast, what it means is that there is less fat and more of what we call fibrous hard tissue or glandular tissue. And it just basically appear as like a white or gray on the mammogram, making it hard to really see if there are sometimes a tiny small tumor cells. It just makes it hard to really see. So it's basically obscures some masses, and because of that, patients can, you know, again, oh, I had my mammogram, they all is well. However, the dense breast tissue obscured a potential tumor that patient could have had. And then with time, next thing you know, kaboom, it become much bigger when if maybe was detected much earlier on an imaging, it could have been taken care of. So dense breast just kind of obscure a mass from being found on a mammogram because it's like this grayish and whitish looking, and we really don't know what is behind. And because of that, a cancer can go unnoticed, undetected, basically creating more danger for a patient. So when a patient then have a dense breast, making it hard to see, now in advancement, we are trying to enhance the mammogram imaging by incorporating a lot of things like even the AI detection process, contrast enhancing process, and a 3D mammogram that hopefully can cut the images in a very thin slice and make it more apparent to basically detect masses that are even very tiny. And also incorporating things like MRI along helps to really detect this potential masses that could have been hidden because of the denseness of the patient breast tissue. So breast tissue, dense breast just create the concern that could there be a tiny tumor hidden that perhaps we are just not able to see clear on the mammogram. And that create a concern for potentially going on without a cancer being detected.
Thank you. How does a woman or even her primary care physician, if they're ordering a mammogram, how do you best advocate for yourself so that you are going to get the best possible screening if you know that you have a dense breast and if you even know that you have cancer in your family?
Yeah, most patients don't even know they have dense breasts until they go for the mammogram, and then the mammogram, the radiology tells them. Oftentimes, especially now, advancement, once again, is ability for the radiologist to notice that, oh, this patient have quite a dense breast tissue. And then they basically offers whether MRI or ultrasound to help. So it's one of those things, let's say a mammogram was done a year ago and it showed dense breast, but nobody did anything about it or said anything about it. Then really patient bringing up to the attention of their primary care or GYN and explain, showing them that, hey, they said I have really dense breast, or even when I touch my breast, it's very lumpy. So I'm concerned that maybe my breast is very dense. And really kind of discussing and advocating for yourself and talking with the primary care, whoever orders them, mammogram, and basically they can help to, well, maybe let's add on ultrasound. And oftentimes when we order mammogram, it gives us even an option to say, perform ultrasound if there is potential concern. So then automatically they know to, go ahead and do ultrasound, or perhaps plan for MRI. But I will say, in the advancement of AI and all of that, our now radiologists are very, very attuned to incorporating very high 3D mammogram so that it can enhance the visual of the breast. So most patients don't even have to advocate for anything, because now they truly are trying to enhance their mammographic imaging by doing 3D mammogram. And that really does help to detect these potential masses that could be hidden in a dense breast. But the MRI, again, you can always talk to your primary care or OB/GYN, whoever orders them, and they can always add on additional imaging like ultrasound or MRI.
Okay. Just a quick question. If you are having your, annual screening mammogram, is the 3D type of screening, is that now standard, or is that something that has to be requested?
A majority of us now, it's like a standard where we just order 3D with
Okay.
tomosity synthesis. So most of them are able to order it as a 3D. And you can always ask your doctor too that, oh, can you please order 3D? But now it's becoming more and more standard
Okay.
testing to order. Mhm. Mhm.
Okay. Now, one other term that, I've heard, and I've had to actually look it up to figure out what it means. Women who have BRCA1 or BRCA2 genetic mutations are, they say, at increased risks of breast, ovarian, and maybe even pancreatic cancers.
Mhm.
What are BRCA1 or BRCA2 genetic mutations, and why are they important?
Yeah, so these are basically genes that helps our we all have these genes, and essentially they are supposed to help us to prepare when there's a DNA damage. They are good genes that are supposed to help to repair problems in our DNA processes, cell dividing processes. But when there's a mutation in this, unfortunately, it just means that they are not able to repair the ability for your own immune cells or your cells to repair the damaged DNA doesn't take place, and that create a problem for cancer cells to develop. So having this BRCA1 or BRCA2 predisposes people to really their cells basically goes unchecked. When it's damaged, goes unchecked, and then that creates this panel of continuously dividing and develop into cancer cells. And the most common type of cancers associated, as you already mentioned, the breast cancer, the ovarian cancer, and pancreatic cancer. Sad to say that, when it comes to things like ovarian cancer or even pancreatic cancer, we do not really have a standard screening compared to how mammogram, we start at 40, you have to get mammogram. There is no really standardized test to say, go ahead and get your screening for ovarian cancer, But when these mutations are detected, then essentially we counsel patients highly to consider getting their ovaries out, getting their breasts out, because, for example, the BRCA1 patient have about 40 to 60% chance that they will develop even ovarian cancer when detected. So it's a very high chance. And so because of that, patients have the option when these genes are detected to go ahead and automatically get their ovaries out to minimize the chance of developing ovarian cancer, and also get their breast out, bilateral mastectomy, to minimize the risk. When it comes to pancreas, it's really tricky in that we are not just going to take out your pancreas. So instead,
Right.
we often refer them to GI, who then tries to do a very high functional ultrasound called EUS, and essentially goes in, and every year patients can get this, even every 6 to 12 months, get this screening ultrasound, endoscopy ultrasound, to make
Sure.
sure that there is no concern for developing pancreatic cancer. So this gene detection just kind of help us who's at risk. And really, it's patients that have this often are very high risk of developing triple negative breast cancer. And that is
Mm.
why it's very vital that when it's detected that we counsel patients on potentially getting mastectomy and all these things done.
Ooh, okay. Well, I'm going to move on to some other questions, and I certainly encourage anyone that's joined us, if you have questions, please go ahead and type them in the Q&A, and we'll get to as many questions as possible. So let's start at the basics.
Mhm.
At what age should women and men begin regular breast cancer screening, and how should this differ based on family history?
Yeah, sure. Really, for now, our guidelines recommendation is 40 for breast cancer screening with mammogram, and that's for the general population. Of course, a patient who have significant family history or BRCA mutation or some form of a high risk. Sometimes we start as young as even 25 or 30, but we do more of ultrasound or MRI than the mammogram. So depending on a patient risk factors, we are even able to begin much earlier, as young as 25 with MRI screening. And then once they reach certain age that we feel comfortable to detect by mammogram, then we proceed to do mammogram. But for general population, we are recommending every year starting at the age of 40 to go ahead and start screening for your mammogram, for breast cancer with mammogram.
Sure, sure. Okay, and as women get older, is there a cutoff age in which women no longer need to have annual mammograms?
So the typical US task force, for example, will say starting age 40 to 74, 75. But for us, we always say as long as patient is capable of undergoing the mammogram, they can do it. Because I have had patient come in at the age of 92 or
Yeah,
82, and they are getting their
okay.
mammogram, and that's how we've been able to detect their breast cancer. So more and more, even past the recommended age of up to say 75, a lot of patients continue to get it, even at much later age, like 80s or even early 90s, continue
Okay,
to get it done.
okay. Um, we hear that there are some lifestyle choices, I mean, diet, alcohol intake, exercise, that
Mhm.
they can, influence breast cancer risks. Let me ask you this. What do you think is the most significant or some of the most significant risk factors for breast cancer that people often overlook?
Yeah, so it's hard because I've had patients come and very
Hmm.
upset because they feel they've done all the checkbooks and here they are.
Yes.
But really, I would say there's comfort in knowing that at least you did your part in a way. The most common things that we always counsel patients on is number one, really keep up with your imaging. I mean, that is why it's not quote unquote lifestyle. It is a lifestyle because it's you keeping up with your annual physical exams, your annual mammograms, and all these things are super important because I can tell you a patient comes and they're like, well, I did my mammogram 2 or 3 years ago and everything was fine. And here I am. It just takes missing one image and then kaboom. I have a patient who had mammogram, say August last year, completely fine. And this year she was like, oh my God, I'm so happy I got it done because I almost put it off that I'll get it, around December. I have so
Yes.
much going on. Yet she just got it done. And then we found a small mass that is cancer. So it just takes skipping or delaying just that one time, and it's enough to develop this cancer. And then other lifestyle changes I highly recommend is, we always preach exercise and things, but these are very important in really helping the process because weight gain, fat cells, when they accumulate,
Yes.
have high risk of contributing to cancer development. For example, estrogen can be made from fat cells. Like when we get a little older or in menopause, how the body really makes a lot of our estrogen is from simply put, a lot of our fat cells using a protein called aromatase. So aromatase basically convert cholesterol, like fat cells, in a very simplified way, there's more to it, into estrogen. And so when I have a 92-year-old telling me, how can I have breast cancer? I'm 92. I've been in menopause forever. And I always have to explain to them that as long as you're a woman, you are making estrogen. And the difference is that, when we are young, our ovaries are making a lot. But once we reach menopause, the body really makes it through converting fat into estrogen. So things like obesity can put patient at risk because the body is basically have all these fat cells and it's asking itself, what do I do with them? So then it converts some into sugar. So then diabetes is a risk factor. It converts some into this fat that it stores, and then it converts some into the estrogen because the body is like, I have this excess. What do I do? And then it just trying to distribute it as much. So then really obesity can be a big risk factor for breast cancer. Diabetes, because when we have sugar, for example, the body is trying to figure out, what can I do with all this sugar? And some of the ways is, again, converting into fat, and then that can be converted into hormones. So what alcohol intake, for example, I always kind of give patient example about men. When they drink so much alcohol, they develop man boobs. And these are all fat and estrogen process as well.
Yeah.
So alcohol, obesity, diabetes, all these are potential high cholesterol, potential risk factors that we often don't think of, that it's even linked to breast cancer. Like alcohol, many patients say, I drink, this much of wine, and they are surprised to know that, well, it can increase your risk of breast cancer. And just being inactive, like not doing much, really not exercising, that inactivity also really increase the risk of breast cancer. So those are some of the really common things that can lead to breast cancer.
Okay. Well, let's talk about some of the good things that are happening right now. You mentioned, AI assisted imaging tools. And I know when I had my mammogram, they mentioned, the AI component that they would be using. What about things like blood-based biomarkers? Are we any closer to being able to, have a blood test that would indicate, what our risks might be for breast cancer?
Yeah, so really, not more and more. I mean, these are not standard. A lot of these are still experimental.
Sure.
We are trying to detect something called circulating tumor DNA, like that. Hopefully, as cancer cells are developing or trying to come back, that they are releasing some cells into your bloodstream that makes it easy to hopefully detect. But so that's where, I don't know if you've heard of the ctDNA, it's very common, or CTC, which is circulating tumor cells. So the whole goal is basically trying to test the patient blood for some biomarkers, and as well as like some DNAs, to help to see, number one, is there cancer cells that are potentially developing, or for patients who have breast cancer and now cured, is there a potential chance that the cells are coming back? These are still very, very experimental. And even when a patient is quote unquote very advanced stage, like stage 3, that we think is cured, or like stage 4 that we think, oh, it's in remission, we are hopefully in the near future will be able to use this testing, ctDNA, circulating tumor cell testing, to detect if there is minimal residual diseases, or perhaps these DNAs that are circulating can give us a clue that, hey, this is a patient that potentially is at risk that their cancer is coming back, or that they are going to develop it. Right now, again, it's not standard of care, it's not approved yet. And so far, some places are using it. The concern with that is, when, let's say, a patient gets tested for ctDNA or Signatera, and the results comes back and say, yeah, we've been able to detect this small number of cancer cells in the blood, we simply don't know what to do with that information, because when we get a scan and the scan shows that there is no cancer anywhere, We are not going to treat the patient just based on this Signatera or ctDNA test result. We simply do not. And that oftentimes really creates a lot of anxiety for patients because they end up being stuck with this test result that is showing that there is potential chance that the cancer cells are circulating. Yet we did a scan and the scan is showing there is no evidence of disease. It's like, how do they sleep at night with the information that, oh my God, here there is this that telling me my cells are, cancer cells are traveling everywhere, but then there's nothing on the scan. So for now, because we still need a lot of ways to figure out the best way to go about it, we are really not, at least Hopkins, we are really not testing for it. I have used it for some of my patients who are stage 4 disease that their scans are good, but they are having some symptoms. I'm concerned. Or when I'm not too certain of them being in remission, then I'm using it. But for early stage, we just simply do not know what to do with this information. And so hopefully down the road, as more testing takes place and we have more information, then hopefully we can use it.
All right, thank you. I want to just kind of talk about surgical innovations. I know things have really changed over the years, but can you kind of explain to us what some of the factors that go into determine whether a patient is a candidate for, say, breast conserving surgery versus a total mastectomy or a partial mastectomy? I mean, what goes into determine whether you keep some of your breasts, all of your breasts, or if it's all gone?
Yeah, so in advance, years ago, before everybody was getting mastectomy, no matter how small your cancer was, you get a mastectomy. Now, in advancement, we've been able to scale more away from complete mastectomy to what is called lumpectomy, which is the breast conserving surgery. And the whole goal is when we combine that with radiation, the recurrence risk and the survival rate are all similar to as if patient had mastectomy. However, not every patient is really a candidate for it. There are some things that will make us not offer it. For example, if a patient have breast cancer, what we call multifocal, and that it's tiny cells, but there are many, many different places. Offering the lumpectomy is a disservice to the patient because how much can we cut from different parts? Other things too could be the size of the tumor. If a patient have a big size of tumor to the ratio of their breast, offering lumpectomy is really not the best approach. Like I have a patient who have a small breast, yet the cancer size was about 9 centimeters, basically taking over her entire breast. This situation, we are not able to offer lumpectomy. So lumpectomy is often offered to people with small masses that is like grouped together, or even if they are a little bit, but they are all grouped in a space that we know we can localize and cut it off. Or patients that, they don't have a lot of calcifications, because there are times that patients have the tumor, but yet there are a lot of calcifications all over that are concerning for possible cancer. And in that case, we just have to offer mastectomy to minimize the patient chance of future cancer. Really from our end, other really reasons why we may not offer is if patient have a cancer called inflammatory breast cancer. It is basically like a fresh eating breast cancer where the patient breast is a wound, basically like a wound it's red and it's wound, and we call it powdery orange, like basically a wound. It's often, we really hardly will recommend lumpectomy just because of how aggressive that type of cancer is. So in the advancement of, we do our best, to do lumpectomy when it makes sense. And I think even patients themselves will know that this doesn't make sense or this makes sense, because when they do ultrasound or mammogram and showing the cancer is in different location, they themselves know that lumpectomy is not the best way. Versus a very small tumor, or even if it's big, but we can shrink it with chemotherapy, that can still offer them lumpectomy. So we really, really are doing our best to go toward the less invasive approach of not doing
Okay.
mastectomy if we don't have to. But there are times that we just have to.
Okay. Well, let's talk about, treatment innovations. We hear a lot about something called targeted therapy, and you hear about, immunotherapy.
Mm.
Have they really changed the landscape of breast cancer treatment?
Yeah, they have. As I alluded to earlier, the triple negative breast cancer, because of how
Right.
aggressive it is, before we did chemotherapy always. Now, in the era of immunotherapy, we've been able to do trials that have demonstrated that combining chemo with immunotherapy and even a triple negative have shown a significant response where
Mhm.
it not only shrinking the cancer, but sometimes we are even lucky where all the cancer disappears. So
Okay.
immunotherapy is definitely changing the landscape of the aggressiveness of the disease,
Right.
because then when patients even finish chemo after surgery, they sometimes are able to go on the immunotherapy by itself to continue to lower the chance of the cancer coming back. Other targeted therapies are us basically trying to detect mutations or proteins that potentially contributed to the cancer forming. Like the BRCA, when we are able to detect a patient with BRCA mutation, we now have a pill called PARP inhibitor that patients can take to continuously lower the chance of the cancer coming back. We have other mutations called PTEN, PIK3, ATM, basically a lot of mutations that precision medicine has helped us to detect via molecular testing, and that because of that, we are able to target these particular mutations with specific pills. Like there's alpelisib, there's TrueCap. All these are pills that ESR1 called Orserdu or elacestrant. When we are able to detect all these mutations, then we refine the treatment to target that particular with a pill.
Okay. For those of us that are not totally familiar with precision oncology, kind of just break that down for us.
Yeah, sure. So really, it's just a matter of we are using a lot of tools now to guide us. And this can come in a form of even detecting proteins or genes through your blood or the tissue itself. And there are a lot of technologies that are helping to assist with that. And the goal is that, okay, can we detect certain mutations or what we call microarrays or all kinds of molecular proteins that perhaps will
Yes.
open doors for patients to be on a targeted personalized treatment, because when we are able to detect this particular mutation on your own samples, then that
Mm.
means that we are able to target that particular protein or mutations with a specific pill. And so it really has helped to shape the field of breast cancer where we are personalizing medicine now.
That's impressive. That's impressive. It really is. Um, what do you think are some of the biggest challenges that patients face after treatment? And I think how can healthcare systems improve survivorship care? Are we being I was part of a webinar earlier on today, and you also have to talk about, the mental health component, when you're talking about, survivorship. You're talking about, people that will go for many, many trials of chemo and radiation. It just feels like a never-ending process. So how do we best support patients, and what are some of the challenges that you really face in getting people to the end of their treatment?
Yeah, so I would say life after cancer can be very challenging in that I've had patients, when they are going through treatment, it's like they have a specific focus, so they are just going and going. And then once now treatment is done, it's like, okay, now what next, right? They are seeing us less. They are not coming through the door as often as, being monitored. And so that really creates a lot of fear. It's like, oh, wow, now they've left me alone. And so some of the ways support-wise is really support groups, creating resources like Life with Cancer is a wonderful organization that offer many, many resources. Our nurse navigators and social workers, we really try to incorporate them in the process so they can provide resources, whether it's through support groups, whether it's through individualized therapies that they can help patients to identify, and many, many resources that are available to help our patients. We have our palliative group. We have, again, a lot of groups that are available here, even at Sibley, that kind of really help the patient basically hold their hand to navigate through the process. And by plugging them with the social worker have been incredible part of patient care in providing such resources, therapy, support groups. And I always tell patients, go on Life with Cancer. And I've had patients really identify not just support group through that, but even a one-on-one therapist that they found to be super, super helpful as they navigate through such a challenging times of their lives.
How do we increase the number of African Americans that participate in clinical studies and clinical trials? The last time, I mean, I was looking at the numbers, it was almost like less than, 3%, may participate in. And when we know that if we're talking about just say triple negative breast cancers or some of the more aggressive forms of cancer that are prevalent, in the African American community more, how do we increase the participation rates?
Yeah. So, historically, right, it's been tough for Black population in general to trust the system of clinical trial enrollment process. And, and that is unfortunate, but history have proved itself wrong in many ways when it comes to the Black population. So right now, we are continuously trying to create awareness of how much advocacy for patients that participate in trial have changed. Like patients have a lot of autonomy through the process, education through the process, and the willpower to decide whether they want to do this or not after they hear all the potential things. So I think now we are really trying to engage the community, going through trusted resources such as even Reverend Donald to basically talk to the congregation, and also really educating the population that now there are a lot of things in place like the FDA process. Now our clinical trial goes through a lot of scrutiny before it can even be applied to any human, not alone even Black. So we really are trying to ensure that patients are very much aware that the process have changed now. Years ago, what happened even with Tuskegee and all this, times have changed, that we are really, education is like the biggest thing, like educating our population and raising the awareness of like what trials means now compared to before. And now the population, at least of oncologists, I feel like we are definitely different than back then, in our passion and interest in trying to advance our population and clinical trials so that we can really refine therapies to our population. That focus is now very much alive. And our goal is trying to representation matter. So trying to also encourage Black population physicians to be involved so that we can hopefully raise the awareness, because oftentimes, like for example, I treat breast and GYN cancers, and a lot of our trial in GYN is not really diversified, and so it's hard to sometimes narrow a therapy that majority of the population was, say, Caucasian, right? And it's not their fault that there are, but like let's say if a trial had about 80 or 90% of a population that doesn't represent the general population, then it's hard to often apply that drug to, say, a Black person. So by us basically trying to encourage our population to be involved, is so that we can refine medicine, and medicine can be applicable to the general population, whether you are white, whether you are Black or Asian, irrespective, that this can apply to us and be effective, right? So we really are trying to put things barrier, like remove a lot of barriers and create the less distract in the system, and rather increase trust in the system of clinical trial error and education of patients, and really getting them involved, educating them, showing them the data, showing them, the reason behind this, like this is what happened in lab, and this is what we believe that it could do. So education have become a big step in terms of trying to recruit our population.
Okay. I want to just make certain that everyone is taking away, some key information, such as we've talked a lot about, different treatments, different types of cancer, but in your mind, what are the early signs of breast cancer that we really should not ignore?
Yeah, it's hard because how many patients are really sitting and examining their breast? But I'm always encouraging everyone. Just, you're sitting, you're taking a shower, or you are sitting watching TV or anything, examine your breast, because it just takes a little, and the more you may say, I don't know how to examine my breast, the more you feel your breast, the more you know what normal feels like. Because when you eventually feel a part of your breast that last month this wasn't there, you're like, last month I didn't feel this in this area, then it prompts you to bring it to a medical personnel attention to get an imaging. When you have, a pain, it's hard because sometimes even women, when they are menstruating, can develop pain in their breast. So when, let's say now your menstruation is done, or like you are no longer, and then the pain is persistent, it's okay to bring it to your, medical team for evaluation. But I think the best thing is really keeping up with your breast imaging as of I can't stretch that enough, because many of these go undetected. Patients often didn't even know that they had a mass. It was really just going through their screening that it was detected. So keeping up with your screening, keeping up with your breast self-exam, because the more you feel it, the more you know what your normal breast feels like, and then you can bring it to our attention.
Do we have to be specially trained or taught to really detect something that is as small as a pea?
It's hard.
Yeah,
It's hard.
yeah.
And even us, sometimes we can't feel it. And that is why it comes back to keeping up with your breast imaging. Because it's just, if it's a very small breast, you're not gonna feel it. Even we are not gonna feel it. So
Right.
that's why we rely on patient really, really keeping up with their breast screening to help us to detect these things early.
When you talk about screening, we're talking about, basically annual screening. Have we moved to the point where insurance will cover, more frequent screening if indeed you have a history of cancer, you have dense breasts, or, are there exceptions in which women can feel that they may be able to get more than one screening in a year? Just wondering.
So it's really not a standard of care it's not even an insurance issue. It's just medically, we don't have enough proof to say. However, for patients who are high risk or dense breast, the frequent screening becomes alternating, say mammogram and MRI twice a year, in that they will get mammogram once a year and MRI once a year. So it becomes every 6 months, they are getting a certain test, whether it's MRI, and then 6 months later, they get mammogram. So that is the approach. But getting, say, mammogram twice a year is not a standard of care. But when we think that you are at high risk, whether because of family history or even your own personal history, we have a tool that sometimes even your primary care can use based on your personal history and family history to calculate your lifetime risk of breast cancer. And when that number is high, that means you are at risk. And even then, we can offer you the twice a year imaging of alternating mammogram with MRI. So it's really risk-based to stratify patients who qualify for that type of imaging. But otherwise, we are not offering like mammogram twice a year or anything like that. And insurance will cover it once we deem you to be high risk. Yeah.
Okay. So when you examine rates of breast cancer year over year, what are you seeing? Are you seeing greater increases in the incidence of breast cancer? Are we catching cancers earlier? What seems to be happening right now?
Yeah, I think that, breast cancer now is very common, sadly. I mean, you meet one patient and she has so many friends or people they know that have it. And
Yeah.
and that has come to the fact that now patients are getting more screening. We are screening much earlier. Years ago, it used to start at the age of 50. Now we are starting at the age of 40. So the screening process now is we are detecting way more. But the good news is also that we are detecting it way more earlier. Compared to years ago, it was more advanced, and now we are able to detect even stage 0, which is DCIS. So truly, while it's more common now, we are able to detect it much earlier and then do something about it.
Okay. Okay. I just want to go back to something that you said earlier, because it made me think of, there was one of my friends mentioned that she was HER2 positive. What does that mean when we're talking about, breast cancer or ovarian cancer? What does HER2 positive mean?
So that is some of the refined or precision ways of us really trying to target the
Yeah.
cancer. So HER2 protein is one of the 3 receptors that we test for. By detecting, so in breast cancer risk in general, triple negative is the most aggressive, followed
Yes.
by HER2, and then the ER and the estrogen positive, the ER and PR is the low. So triple negative highest, and then followed by HER2. By detecting HER2, it just creates opportunity for us to target that particular protein that is driving the cancer. So HER2 just give us, it give itself out that, hey, I am progressing because of this particular mutation that is driving my cancer cells. And so because of that, we are able to then target the patient's cancer cells and hopefully kill it or slow down as much as possible. So it has really opened doors for a lot of what we call, it's not really immunotherapy, but it's like a targeted treatment that really help us to cure or slow down the cancer because we're going after that particular protein. So it's a good thing when we detect it because then we can refine your treatment.
Wonderful. I mean, this just seems that we've come a long distance. I mean, 10 years ago, I don't even think we were talking about, triple negative, breast cancer. And now we have a better idea of, perhaps what is driving the cancer or what is not driving the cancer, and then trying to find treatments that are most appropriate. You said something earlier that was also very encouraging to me, and it sounded as if you were talking about individualized treatments. I mean, based on, which genetic mutation someone may have or may not have. It sounds like we're really at the point of being able to really do targeted treatments that are so individualized. Is that where we are, and is that like really good
Absolutely.
news?
And it's incredible news that now we are able to use molecular testing. For example, even in estrogen positive, we are able to use a tool called Oncotype, where it will help to, based on the patient tumor, can tell me, will this patient need chemotherapy? Would they benefit from chemotherapy or not? Based on that, it can also tell me, will the hormone blocker decrease their chance of the cancer coming back work or not. So all this advancement in targeted therapy in our tools, all that have really create an incredible ways of refining cancer treatment, refining even surgical and detection radiographically. For example, even things like screening process. Now we are again introducing AI, to help to detect the cancer along with the radiologists, like to enhance detection rate, and also things like even the surgery, like how can we do minimal invasive surgery, and that is by using even both digitals and robotic approaches so that we can perform a really good surgery and help the appearance of patient. In that, for example, a patient years ago, they will get a breast surgery and there will be this ugly, big, scar tissue and all that.
Right.
Now, in a process of really trying to refine even surgical approach, we're really offering minimally invasive surgeries. We are using robotic approach so that we can enhance the appearance and the cosmetic appearance of the breast surgery. Even surgical options like deep flap. How can we make the reconstruction process to become more real? And all these are all things, whether it's deep flap, whether using the robot or images. Like even now, our surgeons are able to use a 3D image to really reconstruct how the breast will look like in real life, and then transport that to be able to reconstruct a patient's rear breast. So there are many, many advancements, both in the therapy realm, both in the surgical, and then the detection process as well. All this to really enhance the outcome of decreasing recurrence, increasing survival, and also, after all this big process, that you are not stuck with your look that, oh my God, I look so ugly with
Right.
my breast
Right.
reconstruction, but rather still being pleased that despite all that I've been through, I have
Yes.
a breast reconstruction that I like because of how refined the surgeons were able to use a very direct process or a very reconstructed implant, or
Sure.
even my own tissue, my own process, my own tissue to reconstruct my breast. So there are many, many ways that we really are trying that not only you increase survival, but even the outcome of the surgical process will look good, that you can feel good about.
Well, we are so grateful for people like you that are so passionate about, making certain that women are number one, that they're getting their screening when they should, and that we're trying to find, personalized treatments that allow them, once you have finished your cancer treatment, to still feel, really great about yourself. And so we're just so grateful. You said something earlier that I hope we all can take away is that thinking about breast cancer just during the month of October is not enough, but it needs to be something that we are constantly thinking about. And I want to just also just check in with Dr. Sadler to see if you had any question or any comment that you wanted to make before we bring our discussion to an end.
Absolutely. Thank you. I want to make a comment and also ask a question. I want to certainly say that each time, and I love calling her Dr. Princess, has been with us. She has done a phenomenal presentation. She's extremely passionate about this and knowledgeable. And I really want to thank you and hopefully look forward to finding a way that America can hear your expertise as we continue to do what we do as discussing the facts. But I want you in whatever way you like to share something that men need to hear about breast cancer. I saw something this week about a father who had breast cancer. He and his daughter are survivors, and it was a wonderful story. But we want to make certain that we make it known that that was not a fantasy when we began to hear about men having breast cancer. Say something to the men so that we can help us, and also the women so that they can help us.
Absolutely. I have a couple of patients who are men that sadly have breast cancer. And the issue is that most men are not sitting and pressing on their breasts and trying to figure out there's a mass. And so a lot of times it goes on unnoticed. And when they are finally detected, they are often very advanced stage. And so that's why we are really trying that, hey, when we are preaching on breast cancer, that families also talk to your sons, talk to your husbands, your brothers, all that, because this is real. The best thing is, again, a man may notice something, but they don't want to bring it up because breast cancer idea is far beyond them that, oh, I will have breast cancer. But we really encouraging men to also pay attention to their breasts, their chest. And if something feels different, something feels off, just bring it to your doctor's attention so that we can get the imaging early on, because far too many goes on, they felt something like last year and they brushed it off because it was nothing, and next they come and then it's stage 4. We have a lot of our men who walk through the door, and instead of something that could have been stage 1, now we're talking about stage 3 or 4, because they are less inclined to really examine themselves or bring it to their attention. So men, really, the best thing is really, if you feel something different, pay attention. You are in a shower, feel your breast, chest. And if something feels off, just bring it to our attention. And alcohol, again, is a big risk for breast cancer. And so those are all things that can contribute to breast cancer in men. Diabetes, weight gain, not doing exercise, inactivities. These are all things that can increase risk. And so while we encourage women to do all this, it also applies to men as well.
Just a follow-up, I want to know if there is something that has been kind of covered up by the promotion of women and breast cancer that we are not aware of, that as you, and I thank you for encouraging me to speak to the congregation about breast cancer and all these other health disparities. But is there something, a man that is, the poster for breast cancer, or are there advocacies out there that we need to know about? Or is there a movement to have doctors do as they are now doing with cognitive testing when we go and have our physicals, to have them, take the extra mile and, check and encourage men to do so?
Yeah, more and more we are educating, because sadly, by the time somebody come to us, they often have the cancer already. So more and more we are educating our primary cares and OB/GYNs. Patients don't go to GYN, male patients, but like urologists and like the primary cares, to really incorporate, just quickly touching the chest wall to ensure that there is nothing there. Sadly, because of how men breasts are, we are not able to offer them mammogram unless we detect something, or MRI. But for now, we really are relying on patients to do self-examine, and our primary cares and urologists, like the men health team, to ensure to maybe incorporate, like you said, a little extra miles to check their chest wall to enhance the possibility of finding something.
Well, thank you so much. Thank you for your questions, Dr. Sadler. And Dr. Marcadelli, you are fantastic as always. You have really enlightened us. And I am, again, just very grateful that you've taken the time to come speak with us. I'm walking away with a whole new understanding of what it means, what triple negative means, and what these BRCA genes and all of that we're hearing more and more in the news. I just want to leave one other thing, because it must have been yesterday. I was listening again to TV in the background, and you're hearing so much on the TV in terms of drugs. The last thing that I heard was Keytruda. If you are experiencing cancer, Keytruda may be the one thing that you need. Do you find that ads like that on TV are confusing to
Yes.
people that are going through cancer treatment?
It is, like I mentioned, immunotherapy, that is really one of the ones we use a lot of Keytruda,
Yeah.
and it really has a goal in more and more triple negative. And so I've had patients who are estrogen positive and then like stage 2, and they come, they're like, oh, I saw on TV that I can get Keytruda. And then I have to explain to them where that comes from. So I would say, hey, when you see this advertisement and you are not sure, just come and ask me. I'm more than happy to explain. But yeah, it can be very confusing because they don't clarify the important pieces as to who really qualifies for this thing,
Exactly.
and just throw out there that you have breast cancer, you can qualify, but sadly
Yeah.
does not apply to everyone. We are doing a clinical trial that we are trying to incorporate an immunotherapy even for
Mhm.
estrogen positive breast cancer. So these are all in trial phases where we are trying to bring immunotherapy to also other type of breast cancers, not just triple negative breast cancer. So I would say, come, let's talk. If because you may even be a candidate through the clinical trial. So it can be confusing, but I'm glad our patients are often able to come and ask the questions of, or they send my chat. Can I get it through that I saw
Yeah.
on TV? And I quickly give them
Right.
a call to explain why they are not a candidate.
Well, thank you so much. And again, on behalf of the Sibley Senior Association, on behalf of New Morning Star Baptist Church, we sincerely thank you for your time and look forward to a continuing relationship with you. Thank you so much.
Thank you. And if anybody, the audience, have any questions, I'm more than happy to take 1 or 2 questions if they want to. But if not, yeah, we can adjourn too.
Yeah, I think we've gone through all of the questions. So I do appreciate you, and please, please feel free to come back yet again. And on that note, I am going to end our recording and say good night and thank you to everyone who joined in this evening.
All right. Well, thank you all. And Reverend, thank you. And for the mails, we always let our social workers reach out for posters and such if you need it. But thank you all for having me. It's been a privilege always to be able to be a part.
Absolutely. Absolutely. God bless you.